So this is just depicting normal venous flow throughout the lower extremities. And the next image is showing what a DVT would look like in a woman's lower extremities. Risk factors for having a thromboembolism in pregnancy or in the postpartum period are patients who've had a C-section, if outside of pregnancy or even during their pregnancy they had a thromboembolism. And then the remaining things on here are things that we can test for in a patient's blood. They're expensive lab tests. However, if you see these things on a patient's chart, you should also see that they've been on some sort of anticoagulant therapy, usually Lovenox, switched to heparin, because they have one of these factors in their blood, which make them hypercoagulable. So you don't need to know anything more than that. If you are interested in this sort of stuff, if you were to look at the clotting cascade, having these deficiencies or these things like factor V Leiden just interrupts our normal clotting cascade that you've learned in patho pharm, and then you've also learned in anatomy and physiology. So treatment for the DVT during pregnancy and the postpartum period is largely IV heparin, and then the patient switches over to sub-Q heparin. And also they can go to Lovenox instead to do the 1 day dosing. Same management of any patient with a DVD. They're going to be on bed rest until it resolves, have that leg elevated. All right, where I want to spend some time is on puerperal infection, which just means infection during the postpartum period. It's a bacterial infection that occurs after childbirth. The most common one is endometritis, which is the infection of the inner lining of the uterus. There are other puerperal infections, which is a wound infection happening in the episiotomy site or C-section site, a UTI, mastitis, or septic pelvic thrombophlebitis. For all of these, the patient's going to have a temperature. It's really your big indication. And I refer you again to the risk factors in the book. So let's talk about endometritis. Again, the infection of the inner lining of the uterus. More common after a C-section, but can certainly happen after the vaginal delivery as well. So your woman is going to have signs of an infection, temperature, chills, general feelings of malaise. She's going to have some uterine cramping. The big sign here is that when you press on her uterus, it is going to be tender. Now, I don't mean uncomfortable as when you're all doing your postpartum exams on your patient and she says, oh, that hurts as you palpate my fundus. What I mean by this is she's tender in an infected way. You just lightly palpate and she's, sort of screaming or wincing in pain. And then your other big sign here is that when you go to assess her bleeding, her lochia smells really foul. It smells infected. These patients will end up on IV antibiotics, usually Clinda and Gent. If they're not treated, the infection can spread upward, so into their fallopian tubes, into their ovaries, and it can cause a peritonitis. So we want to make sure these patients are comfortable for their pain that they're experiencing from this infection. This is just an image showing that the infection can spread all the way on up, where it's starting in the uterus and go all the way to peritonitis. All right, so I will leave this for you as well as a learning activity. Just pause me and go ahead and go through this to make sure that you understand the concept of endometritis. All right, the other infection that can happen, the puerperal infection, is a wound infection, either in the episiotomy or the C-section site. Again, you're going to look at the episiotomy, you're going to do your RETA assessment, and you're going to look at the C-section incision as you would any other surgical incision. And should you see any signs of infection that are listed below, you know that something is brewing. What do we do for these patients? They may need an IND and incision and drainage. Obviously, they'll need antibiotics and pain meds. This is just an image of a C-section incision that has opened and is infected. You can see that area in the center of your screen. It's red, that has some tunneling down. That is a sign that she has an infection going on. This as well as a C-section scar. This woman is a little bit further out. I would say she's more, she may even be almost a week out, but she definitely has signs of an infection. You can see the erythema there. All right, two other infections that I want to talk about just briefly because we already have are UTIs and mastitis. So the patient who has either the vaginal birth or the C-section is at risk for UTI if she's received a Foley cath, which, let's face it, all of our women with epidurals are usually Foleyed or straight cathed, and certainly all of our C-section patients have a Foley cath, so they're at risk for UTIs. Mastitis we talked about when we were talking about complications of breastfeeding, so I refer you back to that. But mastitis is a staph infection that causes redness on the breast, and again, mom can breastfeed through this, but refer back to your notes from the breastfeeding material. All right, the final puerperal infection is septic pelvic thrombophlebitis. Now, don't stress about this one because it's very uncommon. It's something that happens in the ovarian veins, so the patient ends up with abdominal, groin, or flank pain, and they get all the other signs of normal infection. But again, this one is interesting because if they have a fever that's not responding to antibiotics, it usually is the septic pelvic thrombophlebitis, which is pretty rare, and we would be treating them with antibiotics and see they're not getting better, and the providers would hopefully order a CAT scan or an MRI and then diagnose that, okay, wait a minute, this is actually septic pelvic thrombophlebitis, and that's why she wasn't necessarily responding to the antibiotics. And so we would take care of her largely the same way you were treating your patient with a DVT. The final points on here are about the affective disorders, and we've already spoken about this as well, which again is why I thought that this material lended itself towards Screencast-O-Matic pretty well. But postpartum depression, I would argue that it's even higher than 20%, but this is what your book states for an incidence. I would know the signs and symptoms for sure of postpartum depression, which largely you already do. This is the list, part of the list, I should say, not the whole list. But again, this patient is most at risk for developing, the patients who are most at risk for developing postpartum depression are patients who are younger or older, have socioeconomic issues. And again, sometimes that woman who is just so type A and is so used to everything going a certain way, a baby changes all of that. So just things to keep in mind and to educate your patient on the signs and symptoms of postpartum depression. This is a huge, huge task of postpartum nurses, and I don't think we do a good enough job educating moms about both the incidence being as high as 20%, and also teaching her that it is okay to report these symptoms, and we want her to report them. All right, these are just factors during the pregnancy that if you're seeing somebody prenatally and they have any of these things going on, you can put her on your radar to be at a higher risk for depression postpartum. After the baby's born, obviously she's not sleeping well. She's got stress from the changes in her routine, feelings of loss for her former, identity because now she has a baby and isn't doing the same things, and she has less free time. All of those things contribute to postpartum depression. All right, and postpartum psychosis is obviously the more severe form of postpartum affective disorders. The signs and symptoms are listed here. Postpartum psychosis is the unfortunate diagnosis normally when we hear about women who, have drowned their babies in bathtubs or driven their cars into bodies of water, attempting to kill the whole family. Their mind is so far gone that is where they go in terms of coping with what's happening to them. Thankfully, this is pretty rare. 1 to 2 women in 1,000 births experience this, and usually these women have some underlying psychiatric illness going on, but not always. All right, this again, is a duplicate slide, same information. The last point I put on here is post-traumatic stress following childbirth. This is really just an interesting fact, so you can just take this with a grain of salt for something interesting. The last page of this chapter had a box in it on page 617, and that box is from a study by Cheryl Beck, who's my dissertation advisor at UConn. Cheryl Beck is a leading postpartum depression researcher. She actually coined this term, post-traumatic stress disorder due to childbirth, and this is just the abstract from her article that was in Nursing Research in 2004. She did a qualitative study through the internet with women who had experienced traumatic childbirth, and what she had realized is these mothers meet all of the criteria for post-traumatic stress disorder due to their childbirth. They're having nightmares and flashbacks of the birth, and so she, through this phenomenological study, which is a qualitative study listening to women's stories, really put together the fact that we can't overlook PTSD as an affective disorder in the postpartum period. And I posted her article in case anyone was interested in it. Not something for test or NCLEX, but really if you're interested in psych or maternity nursing, hang on to that article and read it at some point. All right, and I just wanted to thank you all for listening and wish you a happy Easter weekend.